هو كان في بس تقريبا اختفى. لا دي شنطة دكتور عزة. في ناس عايزين يقعدوا.
حضرتك شايف بس
معلش بس ده فاضي.
Okay, while everybody's sitting down, I would love to introduce Stacey, wonderful Stacey Fogerty-Brown, one of our dietitians. She's been working with cystic fibrosis with us for several years now, what, 5? Something like that. Actually, even before she joined the division, she was working with us. So I'm really excited that she's here. It's a pleasure. So she will talk about improving nutrition in the U.S. in my center, whatever Stacey was working with others that people take into them. So we rely on the how to improve nutrition for patients. So.
Thank you. I'm sorry, I have my throat is scratchy. My daughter parted a cold on me before I left. So I'm not going to lose my voice. We're going to talk about improving CF nutrition. We're going to talk about optimizing several interventions, including salt intake, optimizing pancreatic enzyme replacement therapy, looking at macro and micronutrients, and then considerations with highly effective oxidators. So we'll start with salt, that being the most important thing you're going to start. There. So first, we start with a high salt diet. We recommend for all of our CF patients, whether or not they're pancreatic sufficient, because they're all going to lose extra salt via their sweat. We don't have to go into too much as to why that is. We know it's because of that malfunctioning CFTR tank. So we use extra salt if we have sweat, if we're having fevers, if we're sick, if we're overstressed, if we're in very heavy activities. For lots of reasons that your sodium might be depleted. And then the risks of what you could face if that's not corrected. For our kiddos with CF, poor growth, poor appetite, malnutrition. So something we always have our thumb on. So, how do we start salt? So, for babies, for infants, we start per CFF Foundation guidelines with an 1/8 of a teaspoon. We tell our patients it's the amount of one salt packet you would get from a restaurant. In the United States, like McDonald's or Gordon Food Service, you can get these salt packets, and each one is an 1/8 of a teaspoon. So we start with that, and how you do that is you sprinkle it into applesauce when you're giving your baby enzymes for those who are pancreatic insufficient. And then we spread it throughout the day. Very, very important to spread it throughout the day. Infants aren't going to tolerate it all at once, nor do you want them to have it all at once. If they are not taking enzymes, we will have mother either like rub it on her finger or on a pacifier. Doesn't really work. Some people have suggested if they're breastfeeding to rub on the mother's nipple. We don't see any success with that. What I have seen is maybe mixing just very tiny amount of water, like 1 to 2 ml, and a little bit of water throughout the day can be helpful in that. For everyone else, after infancy, at 6 months, we increase to a 1/4 teaspoon, so 2 packets. And again, spread throughout the day. And then at 1 year old, we have a salty diet. Not too problematic in the United States, but then also adding extra salt too. And certainly you can increase salt depending on what's going on. You have some athletes, we have a handful of athletes in our clinics who use different things to help replace electrolytes that they use. But basically we start salt right at the beginning, we increase it, and then we are really liberal with it. But then what do we do for doing this, and we're not seeing the results that we want? We know when we start salt in infants, they start to grow better. So how can we check? Check a urine sodium. So we have a paper that our surgery cohorts have shared with us. And what it showed, though this isn't specific to CF, just with patients who had some type of gut surgery, but what they found is that urine sodium was significantly correlated with weight gain. So it's not something we routinely check, but if we kind of checked all the boxes, they're not growing, they're not gaining, we're on a high calorie diet, we're doing all the things, let's check a urine sodium. And then this is the algorithm we go by. So essentially we want the urine sodium to be 30 or higher. So when we check, and I have some examples for you on how we replace that. So these are a few patient examples. Most recently we had a 17-year-old who presented to clinic with a significant amount of weight loss and malnutrition. He has a history of short gut syndrome, G-tube dependence, and adherence concerns. He's an athlete, he's a swimmer, very, very active. But as I was going through my diet recall, seeing what he's doing, what I found out is he was not doing any fluids or electrolyte replacement before or during his very heavily active swimming meets. So we did a urine sodium, and he was low at 13. So I had mom start adding 2 teaspoons of salt into his overnight feeds because he doesn't like to do them during the day like he should. But that was the way to help get salt in, and we were able to increase it and help improve a little bit of weight gain. So that's one example. Another example that we have, kind of the same story, but a younger kid. He's 6 years old, 2 feet dependent, has a history of feeding difficulties, oral aversions. He was getting over 2,700 calories as a 6-year-old just in his enteral nutrition, and he wasn't growing. So we checked urine sodium because we had, maximized everything else, and we repleted it, and he's growing a lot better. So this to show you that yes, it can help. It's not something we check routinely, but if we cross everything else off, can we check the urine sodium to make sure they're not depleted, and that could be a reason why all the calories aren't healthy. Next, we'll talk about pancreatic enzyme replacement therapy and how we optimize that. I know you guys don't have all of these that are available, but just to show you what is available. Prions and Pepsi and pancreas, these can all be taken orally. I like to tell my patients it's a Coke Pepsi situation. One's not better than the other. Some patients tolerate one and others just tolerate the other. So I don't think anyone is superior than the other ones. It's also based off of what insurance wants us to try first. So most people with CF are pancreatic insufficient and they need PERS or pancreatic enzyme replacement therapy. If we don't initiate that and we don't optimize it, they're not going to gain any weight, ongoing weight loss, poor growth, poor linear growth. Linear growth falls off fairly quickly in infancy, so we can see that start to replete and get back where they were if we can get their nutrition better and they can consistently gain weight. We can also have nutrient deficiencies, fat-soluble vitamins, macronutrients, fats, carbohydrates, and other micronutrients. So there's a lot of reasons why we want to make sure that they're able to absorb their nutrition. And this is just how normal digestion works as a reminder. Generally, your pancreas will release enzymes when you eat and digest your food. In a person with CF, that's not happening because the pancreatic bile ducts get clogged, and they can't start, and they can't release enzymes like they should. Food's not digested, you malabsorb, etc., etc. So how do we troubleshoot this? That's the thing. So we want to start enzymes as soon as possible. Sometimes insurance is a barrier, but we want to get them on board just as soon as we can, and we instruct our parents at their first visit on how to start administering enzymes. We usually start with a half a capsule because babies are so small. We won't use a whole capsule until they're maybe just a little bit older. It's all based on signs and symptoms, but we start them out low and slow and increase from there. I know from my visits previously, you don't have applesauce here like widely available like we do in the United States. Any type of acidic fruit could be an alternative, but really anything you can get these kids to take enzymes with is better than nothing. Then the reason we want to use an acidic fruit is it helps keep the enteric coating on the beads intact while it's in the stomach. Because those enzymes aren't supposed to come out until the small intestine. So we want to make sure we try to have some balance there, reduce the acidity, and then have good digestion. There is no optimal dosing for pancreatic enzyme replacement therapy. It is very individualized. I could tell you kind of what the range is, but each specific patient has their own dose that they grow appropriately on, that they have GI symptoms are managed. So it's not a one-size-fits-all situation. So some kids need on the very low end, other times we have kids who need max or above max dosing for whatever reason. Parents will start with our infants, we give enzymes at the beginning of every feed, and when they're starting solid, we don't necessarily start giving extra as long as they're eating or having a feed of solid food within an hour of that bottle. The enzymes work for about 45 minutes up to an hour, so that's our reasoning, and they're not going to take a whole lot of solids at the beginning anyway. And then we'll add on enzymes as the food intake increases, the snack increases, so it's a journey, you start working your way up. And then as they get older, they don't have to open the capsules anymore. Right now we open them and sprinkle them in applesauce. I'll say like 8 to 10 years old when they usually start swallowing pills. I think I have like a 6-year-old that's swallowing pills already. I'm like, no way. But working on swallowing pills as they get older as well. So here we do have guidelines from the foundation about optimal dosing for enzymes. They have a recommended, and I put an asterisk there, on the maximum daily dosage, because a lot of us feel like this is really outdated. A lot of our patients are on more than this, and that number doesn't really mean anything to each individual. Babies often will get 2,500 units of lipase per feed. If we're feeding 8 to 10 feeds a day, you can see that math is going to go way over. So we do it very individually, based on weight, and we've had very good results for this. So it's taking a lot of dietitians within a CF to kind of get around this maximum dose. If this was set in place so that this was not fibrosing colonopathy back when enzymes first came out, we didn't know what they were doing. We know what we're doing now. So we use appropriate dosing and adjust as needed. So how do you troubleshoot that though? So what's the timing of the dose? Are the parents giving it before, middle, after? What are they doing it with? Are they missing doses? If you ever do like a diet recall, or say, oh, are you taking enzymes? Yep. Do you ever miss them with snacks? Or no, and then they say yes. So really digging deep and making sure, we're getting all the enzymes in that we can. We don't expect our kids to be 100% adherent. It's just not how life is, but doing it as consistently as possible. And then thinking about if we're having issues and we're not getting good absorption, we try chewing the enzymes. We don't want to do that. They don't work. They cause mouth sores. So the what, the when, the how. So you're kind of like an investigator trying to figure out if they're doing everything appropriately. So when troubleshooting hurt, and when I teach to the fellows, dosing and adjusting enzymes is an art and a science, maybe more of an art, as long as you've been doing it, because there's just so many caveats. But the first thing you should think about is ruling out constipation, because if you add on more enzymes while they're constipated, that might just make the constipation worse. So most times when a family's complaining of, oh, we have malabsorption, but why do we? We just adjusted, we've been going well, what's changed? And it's usually constipation. So if you get them pooping better, then the greasiness resolves. You don't need to add an extra enzyme. So whenever we're thinking about enzyme adjustment, my first question is, do we think we're constipated? A lot of times that's what it is, and other times you genuinely do need to adjust their enzymes. And again, I don't know that you guys have the options for more than one different kind of enzyme, but in the United States, we can try other versions. Like I said, it's a Coke Pepsi situation where one kid can take Creon and go perfectly fine, and another kid needs to go on to Zenpep because Creon just wasn't effective in normalizing stools and growth. Sometimes you can mix two brands together. We don't really do that, just because we have access to all the different kinds of brands, but that can be done if needed. And then just talking about how to dose with families for meals and snacks. How do I know? It's very individualized, but generally you get a bigger meal dose and then you just kind of reduce for a snack dose. A lot of our kids eat snacks that are inside the meals though, because we need them to eat more. So they sometimes can have the same dosage for meals and snacks, and they're still within a safe range. You might think of trialing an antacid with PERT. If you're not getting the best absorption, you're still seeing malabsorption and poor growth. Reducing the acidity can help those enzymes work better in the duodenum where they're supposed to be. You could try fat gram dosing. We don't do this very often. It is the most accurate way to do enzymes, but it's very burdensome to ask families to know how many grams of fat per every single meal, every single snack. Weight-based dosing is very effective and safe. There are some families that do need this though. We've tried everything. We have to go to that route, like, okay, if they have this much fat in their meal, they have this many enzymes. So that's an option. It's just very cumbersome, and I would never want my families to do it. They've got other things to worry about. And then at the end of the day, if you're going through everything, you've optimized the PERT, you're using antacids, and you just, for some reason, still can't get rid of the malabsorption, refer to gastroenterologist, and there could be a workup for SIBO as an example. SIBO can mimic symptoms of malabsorption. So getting the multidisciplinary clinic together to try and understand what's going on here. So looking at macronutrients, how we optimize those. So we know a person with CF needs up to double the amount of the typical calories of someone without CF. And we recommend a high-calorie, high-fat diet, up to 40% of their calories, to meet their increased calorie needs. And when we educate families on this, most of them are kind of blown away that fat is the most calorie-dense, 9 calories per gram, versus carbohydrates and proteins, which are 4. So it's very easy to add this to the diet. Fat is tasty, it's palatable, and it's very high calorie. Thinking about infants and optimizing their macronutrients, most of our kids need more than 20 calories per ounce. Breast milk, if you didn't know, is about 20 calories per ounce. So formulas are made to mimic that. Because our kiddos have such high calorie needs, we often have to give them more than 20 calories per ounce. And then sometimes up to 30 calories per ounce, especially those with gut histories, short gut, that need a whole lot of extra nutrition. In the United States, there's lots of oral supplements available. These are some of the more popular ones. I believe that there's things like this here, but these are complementary as far as complement their nutrition. But sometimes we do have kids that just rely on their Pediasure or their Ensure because they don't eat other food or they have feeding difficulties and things like that. But this is a tool in our tool belt to help improve weight gain. And then, besides buying things like supplements, how can you do it as part of the diet? Doing homemade smoothies, yogurts, adding all the fat-containing things, making them, just as palatable as possible. It's hard with kids. They tire out on food fairly quickly. They like it one day and then the next day don't. So I always try to tell the parents, just be creative and try to change it up. Try not to make the same one over and over and over. Enteral feedings in CF. So we don't hesitate to use enteral nutrition support. It's another tool. Because our kiddos are sick, they can't keep up, no matter how much they're eating, we talk about a G-tube. And we pull the trigger sooner versus later because with CF, this is a long-term issue. So we don't mess around with like an NG for a little while, just go straight to the G-tube. We're gonna need this. It's very, very helpful. And there's a lot of stigma around having a G-tube or getting a G-tube. So having the whole team talk with the family and helping them be comfortable with it. I would say most of our families, after they get the G-tube, they're like, why didn't we do this sooner? Just because they were so afraid of the surgery, of what it would look like, and how their kids would feel, and whatnot. All very valid concerns, but at the end of the day, this is a tool that will help us grow and gain and be the healthiest we can be. A lot of the times, we'll start just with overnight feeds. Try to keep it simple. It's not simple, you know that, but when they're sleeping, they can get their calories overnight, and then you just let them eat whatever they want during the day. Obviously a high-calorie diet, but then we do have patients that do have to have formula throughout the day too, because we just can't get enough in overnight. So it's very individualized, but very generally speaking, when we start on a G-tube, we'll start with overnight feeds to just supplement the daytime, and then tailor it from there. So enteral feedings come a little different ways. Like I said, we usually jump straight to the G-tube for our kiddos, and this is where like a dietitian who helps manage tube feeds and understanding what the formulas are, what they're indicated for, the rates, and things like that. So we troubleshoot with parents pretty frequently who are on G-tubes or enteral nutrition. It can take time. I can think of one family right now off the top of my head. They were very much against a G-tube and thought it was just the worst mistake ever. We had some growing pains with it and trying to figure out how it would work best for them. And now he's gaining and thriving and doing wonderful. So again, it's a bumpy ride to start, but it can be smoothed out and be a really, really helpful tool. And thinking about other ways to optimize nutrition, obviously treating exacerbations, using reflux medications when indicated, but then thinking about how long we want to use an antacid and its long-term effects. Next thing we'll touch briefly on is vitamins. I know in my previous visits they're trying to get something like DECAs and MPW going. So this is what we have. We start these on our babies. Only the ones that are pancreatic insufficient. I don't start it on a kiddo who is sufficient, so I don't have evidence that they need it. So we will start with either one of these. This is also a Coke and Pepsi situation. One's not better than the other. The MPW is just more concentrated. And some babies throw up more on one than the other. Then again, you switch. So we have these options. And what we're doing is we're giving very high therapeutic doses of these fat solubles that these kids are not going to get in a general over-the-counter multivitamin. And then we have some other B vitamins that it does provide in the feed. So then how do we adjust those? How do we try to make sure we're at the right amount of dosing? So we're going to start the diet, we're going to have a diagnosis, start salt, start enzymes, and we're going to start vitamins. Most of our infants in Michigan need to be on some extra vitamin D. We don't get a whole lot of sunshine, so that's generally what we're seeing. But it's very individual for each baby. It's very common to have increased spit up when we have families start these vitamins, and that's one of their biggest complaints. So what we'll say before we switch to a different one, saying, we didn't tolerate that, can we split the dose? Can we get one in the morning, one in the evening? Can you do it a different way? If it's not working in the bottle, can you do it via syringe? Can you put it in a passage for medications? So just trying to troubleshoot ways to get it in before we switch to something else. And then a consideration is, if they're on a modulator, do they need vitamins anymore? To be determined. And then I'll just briefly touch on nutrition and highly effective modulators. So it's a game changer, as we've talked about, for those who have struggled with poor weight and malnutrition. When we got started in our teenagers, they had a very significant amount of weight gain, but it does plateau. So that's the nice thing. In the 2 to 5 group that we started on recently, we haven't seen the significant weight gain that the teenagers had. So that's the difference there. And it has a lot of benefits, it's not without its risks. As a dietitian, you know, as Dr. Nasser mentioned earlier, you know, when we have these kids who are gaining, maybe they're still gaining, and we, you know, what can we pull back? Can we pull back on the extra shakes, the extra nutrition, you know, and consider maybe if you can even reduce the salt. And then consider rechecking fecal elastics. So that, a lot of our families check the fecal elastics, see if they're pancreatic sufficient. So there's some cases where some kids have, but it's not widespread. So just because they're on a modulator does not mean they're going to be pancreatic sufficient. And we retested per request. I've only had one patient convert of the 150 that I take care of. But his fecal elastase is kind of moderate anyway. So that's something to consider too. On a modulator, will that help? I mean, so overall, thinking about nutrition, kids who are undernourished and malnourished are at higher risk for infectious disease. In CF, that means it's a harder time fighting off lung infections. We know that weight and healthy lungs are correlated, a healthy BMI. So we really want to work to, as a multidisciplinary team, to achieve those outcomes. It is so important the first year of life to get the diagnosis, because we know it improves outcomes. So the sooner you can make these interventions, the better.